Ready to start?
Yes, sir. We're ready to start.
Okay, why don't we get started? I only have 45 minutes, and I have a lot to cover. There's two handouts. Are they passing the handouts around somewhere? Pass in the back. There's a orange card, which is a transition card from IV to sub-Q insulin. There's also a sheet that has some tips about using EndoTool. So this talk is called Inpatient Management of Patients with Diabetes and Hyperglycemia. And it's not letting me advance. Well, that's not so good. All right. It's not advancing at all, guys. It's not advancing even on here. Oh, now it is. All right. Now it is. Okay. Just has the jitters. Okay. So objectives of this talk are to review the impact of uncontrolled diabetes in the hospital, explore consensus in patient glycemic targets, discuss iatrogenic hypoglycemia, talk a little bit about algorithms and transitions to IV to sub-Q, and review briefly basal-bolus therapy. This is really about an hour to hour and a half talk. So, but we're going to try to condense it, and I'll try not to talk too fast. So about 38% of all hospital admissions have hyperglycemia. But this is not just diabetes, but people who have new onset hyperglycemia, so-called stress hyperglycemia. And so in this hospital, we have about 900 beds, so about 300 people every day, about a third of people every day are getting insulin. So the three types of patients are those with known diabetes, those who are existing but unrecognized diabetes, as found by elevated A1C, for example, and those who would have normal A1C but just have stress hyperglycemia. This is from New England Journal a couple years ago, showing what stress hyperglycemia is, and it shows that you have cytokines and glucocorticoids, catecholamines, all seem to lead toward hyperglycemia through insulin resistance and so forth. And this has effects both from if you get hyperglycemic, you can get dehydrated, fluid electrolyte abnormalities, as well as cellular effects. And we know that the white blood cell does not chemotax properly when you're hyperglycemic, and you don't lay down collagen and heal your wounds and fibrin very well either. And so, so diabetes is an important comorbidity in the hospital, and people with diabetes tend to have longer stays and cost more money. Here's a study. This is an interesting study. Over 2,000 patients on general medicine service, 26% had diabetes, and of that group, about three-quarters got insulin. They had a threefold increase in mortality. But 12% had new onset hyperglycemia, and only 42% got insulin. They had an 18-fold increase in mortality, which tells you that if you don't address the hyperglycemia, patients don't do as well. This shows you that the mortality, the direct correlation between the mortality and the extent of hyperglycemia. That even with a glucose of 160, you have 3 times more mortality than if you have an 80. And of course, if the glucose is up to, if it's over 300, your mortality is 42%. Same thing showing here. Again, this is both total inpatient mortality and ICU mortality, much greater mortality occurring in people with new onset hyperglycemia are not being addressed. Notice that if you have known diabetes and treat them, there's not much difference in mortality between them and people who are normal glycemic. And it also affects morbidity, shown here that hyperglycemia causes more sepsis, need for dialysis, transfusions, and critical illness polyneuropathy. So high blood sugars cause all these problems we mentioned. And the rate of infection goes up. Once you start to hit about 175 or so, rate of infection goes up dramatically. This is a post-CABG study, about 5,000 patients after open heart surgery. And so this is interesting. This is from Boston, where they found a single glucose over 220 was almost 6-fold increase in nosocomial infection. This is a post-op. So in the surgical patients particularly, it's really important. And in my early years in practice, when I was at Georgetown, you see a lot of people that had CABGs, and after CABGs had deep sternal infections. By the time I came here 15 years ago, the surgeons were starting to use intravenous insulin therapy in these patients after heart surgery, and the incidence of the wound dehiscence is almost non-existent. We almost never see a chest dehiscence anymore in patients who've had heart surgery because they're addressing it. In fact, it's interesting that every patient that has heart surgery comes out of the OR on EndoTool, whether they're diabetic or not. If they don't need it, it's turned off. So they don't allow anybody to become hyperglycemic post-op after heart surgery in this hospital. Okay. And all these things, of course, cost more money. And I mentioned about the leukocyte factor. So chemotax doesn't work well when patients are hyperglycemic. And there was a study actually done in our hospital. Dr. Estrada used to be in general medicine here, and our heart surgeons did a study, showed that they could, by every 50 milligram increase in glucose, added almost 3/4 of the day length of stay in the post-CABG patients, and a Portman study showed the same kind of thing. So clearly, at least in the surgical patients. Now, the medical patients may be a little bit different. We'll try to cover that. So there's a question whether the target should be lower. There was an important study that said people should have a target of like 110, but then another study called Nice Sugar said have a target of 140 to 180. So the study that had the single center that asked for like the 110 level, the key thing about that study is people were getting dextrose. They're getting calories, either TPN, tube feeds, or IV dextrose. Where in this other study, they were not. And so it turns out if you're giving IV insulin drips for people, you really should be giving, once, let's say if it's DK, you get them corrected. But once they're corrected, you have to continue that. You need to continue insulin drip. You need to give calories as well to have the best outcome. And there's sort of a J curve. So if you see patients that are hypoglycemic have increased mortality, but the mortality is higher if you're hyperglycemic. So it's kind of a J curve is what it turns out to be. So what are the numbers that are recommended? So most people are recommending numbers about 140 to 180. And so definitely when you get above 180, you're getting to areas where your risk goes up. The problem on trying to get it below 140 in the 110 to 140 numbers is that the sensors we have, the monitors we have, aren't, the finger stick testing is not that good. Sooner or later, you're going to have real-time testing. So just like you get your central pressures and all that kind of stuff, you know the glucose every 5 minutes, because we can do that in the outpatient setting now, but it's not quite there in the inpatient. So it's recommended now as a threshold of 180, and 140 to 180 is the target, and we define hypoglycemia less than 70. So in the hospital setting, the American Diabetes Association recommends you do not use oral agents, use insulin. If they're in the ICU, use IV insulin. If they're on the regular floor, or they're transitioned off the ICU, use sub-Q insulin. When you use sub-Q insulin, we don't use sliding scales. Some of you may have come from places where you had sliding scales. The word sliding scale here is a bad word. We don't want to use it. We use basal-bolus, and we'll talk about that. So the problem with oral agents is they don't work very well when patients are sick. And in fact, the sulfonylureas can cause hypoglycemia. It's a real serious problem with them. So we try to avoid all these oral agents. There's very few situations, maybe people who are in rehab or in psychiatry or people going home soon, you can add oral agents. Metformin, there's always this possibility of lactic acidosis, not very common. TZDs can cause significant heart failure. So for the most part, we don't want to use oral agents in diabetic patients in the hospital. We want to use insulin. And that's what the recommendation for the Society of Hospital Medicine is, as well as the American Diabetes Association. So that is the consensus recommendation. Do not, so if you have a patient coming to the hospital on oral agents, stop the oral agents. If glucose isn't higher enough, the treatment, you only use insulin. You don't use oral agents in the hospital setting. And the reason for it is that insulin works quickly. It's the best therapy we have. And IV insulin works better than sub-Q insulin, but they all work very well to control the blood sugar. So let's start off with the IV insulin first. So who gets IV insulin in the hospital? Obviously, people with DKA, non-ketotic hyperosmolar state, people before and after surgery who have diabetes, usually in the cardiac unit, anyone's hyperglycemic, and critical illnesses. Type 1 patients have to have insulin. You never stop the basal insulin on the type 1 patient unless you're putting them on a drip. Steroids, it's very hard to treat people on high-dose steroids with sub-Q insulin. You've got a patient getting a lot of steroids, their blood sugar hitting 200, 300, they really should be on IV insulin. And if your blood sugar is over 300, you need to be on IV insulin. In the L&D suite, they use it, and they also use it sometimes to help put people on IV insulin to find out how resistant or sensitive they are to help figure out what kind of sub-Q program they need. Okay. So there are two kinds of ways of giving IV insulin. There's a paper protocol using columns, and if your blood sugar is in this column or you're resistant in this column, it tells you, based on that one blood sugar, what your IV insulin rate should be. The other way is a computerized program. There's about 3 or 4 of these in the country. We have one here called EndoTool, which I want to talk to you about in a little more detail, because you may not, if you come from elsewhere, you've probably never heard of EndoTool. It's a computerized software developed actually by a nephrologist, and it's now available on all the ICUs, SIU, MIU, BGSU, NSU, CVIU, CIU, 3 East, 1 South, and L&D. Is that right, Sandra? That's Dr. Hardy, by the way. Sandra Hardy is the PharmD here, who's in charge of the inpatient diabetes program with me, as the director of the program, manager, and so she is your resource person for all these other issues. So how does this whole thing work, this endo tool work? It was developed about 10 years ago, and it was actually developed by a nephrologist who was kind of a math genius. And before we had that, we had something called Glucomander, and which was a similar program, but it had a little tablet, which was always breaking down, and they had it go with the patient when they moved. So we had it for 5 years. In 2009, we switched to EndoTool, which is strictly software, so it can be put on any computer for any patient in the hospital. But it has to be on that unit. So only the units I mentioned have the capability of the EndoTool. If you're on another unit and you want IV, you have to use paper protocol. So the idea of this is that your blood sugar is changing all the time. It's like a vector. So it's traveling in direction, and it's going in speed. And what this does, it looks at where the trajectory of the glucose, where it was 2 hours ago, where it was an hour ago, where it's going, and based on that determines what the rate should be, determines when the next finger stick blood sugar should be, and if it's high, may also recommend giving a bolus in addition to changing the rate. So just think about 3 kinds of automatic things. So you have cruise control. So you put your cruise control on 65, and you're driving a car, but you fall asleep, and you can still go off the road and have an accident. So it's not very great, but it's better than nothing. Thermostat, same thing. You know, it's not too good. But autopilot in a plane is a really cool example of a control thing, because in autopilot, what it does is it doesn't just set the speed at whatever it is, 600 knots or something. It also is looking at things like the altitude, wind shear, measures all kinds of things in a computer program to help determine what the ideal speed and altitude is for that plane. So in that respect, we're kind of working with that type of math control system. So if you look at relationships here, what we're trying to do is have a correct way of determining what an IV rate should be based on the current blood sugar. So let me give you an example. So, so we want to correct highs, and we don't want to have lows. So let's say, for example, we have a patient, and their blood sugar at 1 o'clock is 300. However, an hour later, it's only 285. So clearly what's happening here is they're not getting, assuming they're getting the insulin, that's not enough. So we'll then what it'll do is say, okay, we've got to then increase the rate, give a bolus to try to bring this down. So in this case, whereas on the other hand, on the paper protocol, you would just keep, you know, change at 2 o'clock, change again at 3. This time, what the computer will tell the nurse is, okay, increase the rate, give this bolus, and then now recheck again in 30 minutes. Don't wait another hour. And this is an upregulated feedback system to prevent highs. Conversely, if the patient's blood sugar, say, was 300 at 1 o'clock, now it's 150 at 2 o'clock, so it's dropping. We don't like blood sugars to drop too much more than about 100 milligrams an hour. So it's dropping 150. Whoa, look out, we may be, because we wait till 3 o'clock now, it may be down to 60. So there's all these negative feedback regulators in the algorithms, which then will tell the nurse, okay, reduce this rate, so cut the rate back down, but then also check again in 30 minutes, because then we may have to make another calculation. So it's calculating based on rate of change, and it's much more accurate than just doing a paper protocol. So this is some actual data I presented at a national meeting in Chicago looking at hypoglycemia. And one of the big advantages of this endo tool is you have less hypoglycemia. So if you look at here, you can see that we had 8,000 patients' data, 260,000 blood sugars. And you see in overall, the hypoglycemia less than 70 was about 1%, less than 40.04%. And if the nurse did what she's supposed to do, which is make the change within 15 minutes, it's even less than 1% here, 0.02%. So you really have a lot less hypoglycemia if you use this thing than you can get with any kind of paper protocol. So you've had an orange card passed around. This is a transition card. And one of the biggest problems we have in the hospital, I think we have 2 big problems. One is transition is wrong, and 2 is hypoglycemia. So the transition issue is how much do you give the patients. So basically, you can do it based on the patient's weight, or you can do it based on the insulin infusion that's required. But that insulin infusion should be stable. So for at least 6 hours stable rate, say 2 units an hour, then you would use that as a calculator for 6 hours, and then times 4 would be for 24 hours. So you typically would do 60% of that rate would be the dose of the basal insulin, for example, glargine. So if so the patient's getting 2 units an hour overnight, And then you would figure a loading dose, and you would follow that. It's all on the card to show you how it's done. And then you would then, if you want to then, if they're going to eat, then the same, you take that same equivalent dose, divide it to 3, and that would be the perennial dose. So I hope it's not too confusing, but so let's just say, for example, patients getting 1 unit per hour. So that would be 24 units. So if you would take 60% of that, that would be their dose of their glargine, and the same percent with their meal dose if they're eating. So when you transition as shown here, and this is pretty much fairly stable when you want to do that. If the sugar is unstable, then it's probably not a good idea to transition them, and you really shouldn't transition people if they're not eating. If they're not eating, it's better to keep them on the drip. If they're on tube feed or TPN, you can put them on, you can transition them, but you'll probably need to have, for example, on TPN, you have to put insulin in the bag, and that can help enough. You may also have to give, say, regular insulin every 6 hours. When patients are on tube feeds and TPN, we tend to give regular insulin every 6, but if they're eating, we tend to use the Lispro insulin Humalog with their meals. It's kind of shown here. It's kind of a busy slide, and you can transition in the morning or in the evening. It really doesn't make too much a difference. The nurses are kind of used to giving the glargine insulin about 10 p.m., so we sometimes transition then. But remember, the important thing is they're on the IV. You have to wait at least 2 hours before you turn that drip off after the sub-Q insulin, because that sub-Q insulin has to form a depot in the tissue, and until that does, you can't really turn the drip off. And one of the biggest mistakes we see are people, they write for the sub-Q and turn the drip off, and what happens is the blood sugar starts going back up again. So at least 2 hours. Some people feel you should wait 4 hours, but at least 2 hours if you're giving glargine or Lispro insulin. So how much you give, I mentioned this already. So if you give a weight-based would be for a normal type 2 patient about 0.25 units per kilogram if they have normal renal function. If they have impaired renal function or liver function or they're very thin, type 1, you might give 0.15. So that comes from what your total might be. So total for a type 2 would be 0.5 units. So 0.25 would be the amount of the glargine. That does not include the meal dose or correctional dose. So you can use the patient's home dose, but I will tell you that's the worst way to figure out insulin based on the home dose, because a lot of times the patient aren't taking the dose. We had one the other day with crashing, because supposedly they're on 75 units of Lantus a day. The patient wasn't taking Lantus. They gave 75 units of Lantus, patient crashed. So the patient's home dose should be viewed with suspicion, especially if the A1C is high, or if the patient has not been testing, maybe non-compliant. So, and also the home dose may be fine when they're home, but now they're stressed out, they're sick. It's not going to be the right dose either. So. Or it could be at home, they're eating everything that wasn't nailed down to the table. They're eating 3,000 calories a day. Now you got them on 1,400, 1,800 calories a day, and of course they're requiring less. So the home dose is not a good thing. So I like the weight-based dose, and what I usually do is I look what the weight-based dose is, and I look at the IV doses, and I kind of see between the two of them what I want to do. So we feel that when you give a dose of glargine on transition, you truly shouldn't use more than about 48 or 50 units. If you use more than that, there may be an issue, and then you might want to consult endocrine if you want. Okay, and remember when people have decay or surgery or stress, become insulin resistant, but then as they get better, the insulin resistance resolves. So a big problem we have is a lot of people order for insulin, and then what happens is they don't make the changes because all of a sudden the patient's getting better, the stress is being relieved, and now what happens is they started crashing because you got too much insulin on board. So that's a problem. Plus transitioning too early, when you switch them off to sub-Q too early, that can be an issue as well. So transitioning is a real important thing. Okay, I think I went over that already. All right, so basically you have to remember if you're given a push on clear liquids, there is calories in the clear liquid, and it's sort of like a 6-day diet we use for diabetics, so that's fine. If they have insulin, you can give them the calories. It is an issue. American Dietetic Association recommends 200 grams of carbohydrate per day. So that would be, so if you give it, remember you give an IV dextrose, a liter is 50 grams. That's 200 grams in 1 liter, 600 calories. Okay, so we have order sets. So we really want you, when you write an insulin order, to go in the insulin order sets. Don't just write insulin. Go to the order set guide and pick the order set you want. The order set will do everything for you. It'll make it easier once you use them. It's much easier than try because it comes in. The finger sticks come in. The education part comes in. The hypoglycemic protocol, which they need, comes in. So when you order insulin for anybody, except possibly when you're giving insulin to lower potassium, that's a separate issue. But if you're giving insulin for diabetes, hyperglycemia, use the order set. And order sets include finger stick testing, call parameters, the protocol, instructions for education, nutritions. We try to get, unless the patient just had A1C in your clinic a few weeks ago, we try to get A1C in every patient comes to the hospital. Keep in mind, if they had a blood transfusion, A1C is non-valid. If they're severely anemic, hemolytic, it may not be valid. If they have sickle cell, it won't be valid. So certain things where A1C may be incorrect. So this is a list of the order sets that we have in the hospital, and you can access this, and you can download this whole thing from the website. So this is the order set number 21005. Gives parameters, one to call the nurse, the hypoglycemic protocol, education, finger stick testing. And notice that we usually do, most of our patients who are eating on insulin, getting 4 shots a day, we usually do a blood sugar with each meal, bedtime at 3 o'clock in the morning. The 3 o'clock is mostly a safety check to make sure they're not hypoglycemic. If they're NPO, we usually then are on continuous tube feed or TPN. We do finger sticks every 6 hours instead. And here shows what I'm talking about before about the amount of medication they're receiving. I think I went over this already. So the initial dosing for patients, again, type 1 patients about 0.4 units per kilogram per day, type 2 about 0.5. Again, less if they have GFR 10 to 50 reduction, dialysis even more reduction. Very skinny people, older people will need less. It's always better to err on the side of caution and give less. Once you put too much insulin in the bag or you give too much sub-Q insulin, the train's out of the station. You can't stop it. You give a big dose of sub-Q insulin, it's not like a drip. A drip you can turn off. The half-life insulin is 5 minutes. You turn a drip off, there's no insulin on board in 15, 20 minutes. You give a big dose of sub-Q insulin, you give 40 units of Lispro, Humalog, it's there. It's too late. You can't stop it. It's going to be there. So you think carefully and be conservative when you start. On the other hand, if the sugars aren't coming down, then be aggressive to try to get them down. So are there any questions before I talk about hypoglycemia? Any questions about endotool or transition? Yes? Wrong. Wrong. So here's the story. No, it's okay. They're wrong. A lot of the attendings are wrong. It's okay. It's okay. So you can use endotool for DK. The point is endotool is only based on finger sticks, not on lab blood sugars. So the highest blood sugar it reads is 500. So if it's above 500, you start off at that dose, and then when you recheck it again, when they tell you to, you still say it's above 500 until it actually comes down to the range it can be read by a finger stick. Because the machines only read it about, like, I think, is it 500 or 600? 500. So if it's above 500, it'll just say high on the machine. But you can do it. Endotool will work for DK. It's there. It's made for it. So the only thing we have to remember about DK is you keep showing high until they're above 500, then you follow the protocol. But also when they get down to about 200 or so, you're going to have to change their IV and give some dextrose. Get normal saline. Instead of normal saline, you give D5 normal when they're down to about 200. It is close. It'll close. Part of the reason it's not closing may be because there's no calories. Because remember, the acidosis is occurring because you're breaking fat down from the fat cell. When you give insulin, you want to drive the fat back in the fat cell. But also you need to have need to have glucose on board as well. So the gap will close. And the gap's very important, but I would also look at the bicarb level and the pH are probably more important. The gap can be misleading sometimes. But it will close. Trust me, it will. But if they're still acidotic, it's not time to transition them. You want to make sure, number one, they're no longer acidotic, and number two, they're able to eat before you transition them. And again, a big mistake is people transition too soon. And if they're in DK, probably they're either type 1 or very stressed out type 2, which means if you stop the insulin too soon, they will go right back into it again. And that becomes a never event in the hospital. So if the patient was not in DK and you put them in DK, you are going to be dinged as doing something wrong. Okay. So let's talk about any other questions? That's great. Good question. Thank you. Hypoglycemia. So what causes hypoglycemia? Well, the things we found is, first of all, people give too much insulin. That's number one. Number two, people are made NPO and they get insulin sometimes more than they need. And particularly if they're on TPN with calories coming in, or tube feed, that's stopped. So you've given sub-Q insulin now, and you're based on a tube feed. The tube feed, the patient pulled it out, or they went off the floor, turned it off, whatever. That's a problem. And also same thing, you're on high dose steroids and you're reducing quickly, you're not cutting insulin back. So, and also medication errors. People just give way too much And another problem is people on renal patients. Renal patients need less insulin. You've got to be very sensitive to that fact when you see CKD patients. So, okay, so treatment is important. If the patient in the hospital usually use D50, and they really recheck the blood sugar again. They will be calling you, but don't over-treat them. You don't need to get their blood sugar up to 300. Just need to get it back up, say up to 100 for the most part. And that usually is not a big deal. But if you don't put the hypoglycemic order set in, you won't have the protocol. So if you put a order set for insulin in, the hypoglycemic protocol comes in automatically. The nurse does not have to call you to get it in. She will automatically treat the patient and then call you if necessary. So we try to do these things as shown here to prevent the hypoglycemia in the first place. And so one of the ways we prevent is not using sliding scales. Another way is not using NPH insulin. So our basal insulin in this hospital is glargine, that's Lantus, and our perennial insulin now, it used to be the Novolog Aspart, now it's the Humalog Lispro. And basically there's really no difference between the three short-acting insulins, the Humalog, Novolog, and Pedra, but there is another insulin out called Detamir or Levemir, and we don't have that in our hospital here. Some people use it. We think it's the glargine or Lantus is better because it lasts longer for most people and you need less. So a physiological approach, I already mentioned this already. I showed you that already. So you may have heard about the ADL algorithm. The ADL algorithm says start with metformin first, right? Well, if they have uncontrolled diabetes in the hospital, you don't use the algorithm. That's only for outpatients, an outpatient insulin, outpatient algorithm. If they're sick and they're in the hospital, we go with insulin, and we don't use sliding scales. We use IV or sub-Q. So this is kind of the holy grail of diabetes, and this is what all of us would look like if we would measure our insulin level. So if you haven't eaten lunch right now, your insulin level is here down to about 10. If you just ate at lunch, it's up over here. So you see the body makes insulin in two ways. It makes the basal insulin all the time, and that prevents breakdown of starch by the liver, glycogen breakdown, prevents breakdown of fat, and then it makes large amounts, up to like 60 or 70 microunits occur when you eat a meal, particularly based on carbohydrates. So that's what normal insulin would look like. If we can reproduce this in a patient who doesn't make insulin, we would have a very well-controlled patient. So again, you have basal insulin for everybody. It's always there, whether you eat or not. So if you were to skip this meal, your insulin level would be like that. And then we have the so-called bolus insulin, which is going to be either a prandial insulin or a correctional or supplemental insulin. So basal is needed to meet metabolic requirements. Prandial is for nutrition. And then supplemental correction is when your patient's high because maybe they're on steroids, some of the reason you want to correct them. But just using correction and basal alone is not adequate if the patient's eating. If they're eating, they have to have prandial. So if the meal comes on, if the meal occurs and they don't get any insulin, and then the nurse holds the insulin, their blood sugar is 110, then the next time she checks, it's going to be 200 because she didn't give any insulin. All right. So basal, depending on the patient, is anywhere from 40 to 60% of needs, usually about 50%. And I've already mentioned what the insulins are, and they're we've talked about that a little bit. And you just can't give if you just give basal alone and they eat, what happens is you still don't able to take care of the peaks, and you have too much insulin, you're not eating, and that's where people get in trouble. So that's the problem. We don't want to give so much insulin that they get crashing when they're not eating. So what you have to do is give bolus insulin for the meals, and the bolus insulin works very quickly. And these are the bolus insulins we have. Get rid of this here. Available today, and I mentioned on our formulary we have Lispro. You see it starts in about 15 minutes. So patients who are outpatients can get this insulin right before they eat. Now, if you got a patient in the hospital that's not eating accurately, sometimes they don't, what you can do is you can order the Lispro to be given after the meal based on how much they ate. So you order, say, 8 units for the meal, they eat the whole meal, they get 8 units. They eat half the meal. Right afterward, they get 4 units. Quarter, maybe 2, and if they don't eat anything, not give it to them. So you can adjust this one as long as you have the basal insulin on board. You can adjust the meal dose and give it right after they eat based on how much they're eating. And if people that don't eat regularly, this can avoid hypoglycemia. And you can do that. You put that right in when you edit your orders. Nurses are very familiar with that concept of looking at how much they ate and deciding how much to give the patient. So if you just gave regular and NPH insulin, you see there's not a very good overlap with the normal, shown in the red here. If you use a short-acting insulin and the glargine, it's still not perfect, but it's a lot better than the other insulins to try to reproduce the normal. So again, we're giving insulin as basal, we're giving mealtime insulin, and we're giving stress or correctional insulin. And how much, so you notice in this slide, you can see the basal insulin really doesn't change too much. What changes is if they're getting tube feeds, they need more prandial insulin. If they're sick or stressed, they need more stress doses or correctional. So again, the basal is probably about the same, but it's the other insulins that they need more of when they're eating too much, or they're eating or getting tube feeds. And you remember, like TPN is a 50 to 70% dextrose. It's very high. Tube feeds, they'll run up blood sugar. So a lot of people who are not even diabetic will then become hyperglycemic on tube feeds and TPN. And you have to address that, as I mentioned at the beginning of the lecture. All right. So the basal, and then you have the nutritional. Okay, scheduled insulin, and then the correctional insulin. So we'll talk about how we come up with the formula for correctional insulin in a minute. So there's a guy named Paul Davidson who figured out something very interesting. He found that in the literature it was found that a typical 70-kilogram person would take about 50 units of insulin a day, and if they gave him one unit of insulin, their blood sugar would drop 30 milligrams. He said, oh, that's interesting. I wonder if I give them 30, if they're on 30 a day, would it drop 50? He kind of figured this out, and he multiplied 30 by 50. He got this 1,500, which is like constant, like pi. And to kind of figure out, meaning that the more insulin, the higher your dose of insulin, the less sensitive you are to the dose than you were, and the larger your dose, the more sensitive you are. He called this insulin sensitivity factor, and it's been published. Some people use 1,700, but we typically use 1,500 rule. So, for example, if you're taking about 40 units a day, one unit drops your blood sugar about 37. If you're doing 50, it's 30. If you're doing 100 units a day, one unit only drops at 15. 250 units, one drops at 6. On the other hand, if your total dose is 10, one unit's going to drop you 150. So when they call you with a blood sugar in a patient, and you just say, the patient's blood sugar is 300, oh, give him 5 units, you really need to know what patient you're talking about. You're talking about a skinny little, lady with renal failure, and she weighs, 30, 40 kilos. You're talking about someone who weighs 200 kilograms who's on a lot of insulin, because it's going to be different how you correct that. So the formula then basically is you figure out what the actual blood sugar is, you try to figure out the ideal blood sugar, the mid-target, and you try to get there. So, for example, in this case, the blood sugar is 160, and the target, the mid would be 100. So that would mean that 1 unit, so you take 60, divide by into 1,500. This patient, in this case, the patient's taking 60 units a day. So 60 divided into 1,500 is 25. So 1 unit drops to 25. The patient's blood sugar is 160. You want to drop 60 units. So 60 divided by 25 is about 2.5. You round down to 2 units. So that's what the story. So you take the 1,500 divided by the dose, and actually in the computer program, it's right there. This whole thing will be calculated for you. It's in HealthSpan. You don't have to do the math yourself. So say you got a new diabetic, never been on insulin before. How do you know? You don't know what their total daily dose is. What you do is we estimate it by just taking 0.5 times their weight in kilograms. So if they're 100 kilograms, then you say, okay, you'll assume the total daily dose is going to be 50. Now, you do this, and if you find it's not working or going too much the other way, you can cut back. So if you're doing 1 unit for 50, and you're not getting anywhere, the patient's sugars are still high, you might do 1 unit to 30. On the other hand, if they're doing 1 unit to 30 and the patient's crashing a lot, you might go to 1 to 60. So you need to adjust this based on the response to this factor. So again, I think I mentioned before, here's another patient requiring 50 units in 24 hours. So therefore, 1 unit will decrease blood sugar by 30 points. So the correctional one is an adjunct to basal and prandial. It's not to be used by itself. Correctional by itself is a sliding scale. We don't want to do that. And also, sliding scales has one size fits all. So again, whether you're very sensitive, just lost the whole thing. 20 every 12 hours. Okay, we okay here? It's not on there. Oh, it's on there. That's right. Okay. I don't know. Okay, hopefully we're okay. So here's a correction formula again. Here's another one. So I think you get the concept. So I want to tell you about 2 cases in this hospital, real cases, that occurred before I went on this program. So one patient had a blood sugar of 265 and was on IV insulin requiring 192 units to control them. The other patient had just been admitted, had a blood sugar of 412, and their home dose was 17 units. And I want to tell you what happened. And this is when we used to use sliding scales here. And this was a typical sliding scale. If you came elsewhere, you've seen this. This is what a typical sliding scale, one size for all. So the first patient was on insulin drip and was getting 8 units an hour. So it's about 192 units. The finger stick was 265. Well, if you divide the 192 into 1,500, that tells us that this patient, 1 unit's going to drop their blood sugar about 8 milligrams. That's all. 8, that's it. So what does the sliding scale say to give? 4 units. So 4 units, all right, 8 units, that's going to drop at about 32 points, which will give you a 234. It's like peeing in the ocean here. So what does the patient really need? Well, if you take 265 and you say your target's 100, divide by about the 8, you need about 20 units to get the blood sugar down to that target. And in fact, so what's happened is all these people who are insulin resistant, nothing happens. So the big people, very resistant, you give too little based on the sliding scale. That's bad enough as it is. This is worse. So here's a patient who was only on 8 units of glargine and 3 Humalog with each meal, 17 units. Blood sugar is 412. Well, sliding scale for 412, you've got to give 10 units. However, if you divide the 17 and 1,500, 1 unit's going to drop at 88 points, right? Well, if the sliding scale says take 10 units, then 10 times 88 means you can drop your blood sugar 880, which will lead to negative numbers, right? If we calculate the correct way, you divide 88 by this difference between 412 and your target, it's only 3.5 units. So you need about 3 units to get down to about 148. What happened to this patient? This was a real case, real patient. This patient got 10 units, had a seizure. The next glucose was 14 after 2 amps of D50. So in this case, the sliding scale was dangerous. So for these reasons, we got rid of sliding scales in this hospital. Other hospitals are still using them, including some of the other Viden places. We are trying to work on that, but I've got a big issue here. I can't worry too much about them yet, but we're trying to get them in the modern age. So if you came from a hospital somewhere else where you're a medical student, they're using sliding scales, or you leave here, go somewhere else that has sliding scales, you tell them, they used to also use glass syringes. They used to, treat people with arsenic for syphilis. I mean, come on now. You got to update your stuff. All right. So this is a technical review. Tells you that we like the Basal-bolus approach, as shown here, and the traditional sliding scales have shown to be, ineffective at best, and as I showed you, dangerous at worst. So I went to this again. All right. So we've come up with something called the principles and practices here for Viden Health. I just put this VMC, but it's for you, but it's for all, going to be all the Viden. And basically that insulin therapy is the optimal treatment for high glucose and diabetes. And we want to prevent hypoglycemia. In the hospital setting, we want to not use oral agents. And sliding scales are ineffective and dangerous. And critically ill patients do better with IV insulin. So all people in the ICU should use IV insulin. We don't like those premixed insulins, those 70-30 premix. They're not that great in the outpatient setting, but in the hospital, it's worse. It's about the worst thing you can do is give premix. So we urge you not to order premixed insulin in the hospital. And if they're going home in NPH, you can still keep them on the glargine, Humalog, and then they can switch later they go home. But you might as well treat them the best way you can in the hospital. And when you go home, we'll worry about that when they're ready to go home. Finger stick testing is necessary, and the target. So our targets are basically to keep between 70 and 180. And hopefully, so less than 70 is bad. 140 or 180 is kind of a good range to be in. Above 180 is not so good. And the standards we're doing is to try, as I mentioned, keep it 140 or 180. And some patients may be lower, depending on the situation. And we've talked, and patients need carbohydrate-controlled diets. If you see the patient, if you come up there and a patient's having French toast with regular syrup and orange juice and all that stuff, you might want to check what their meal is. And you can put in the meal carbohydrate, control meal, and also put like no fruit juice, that kind of thing. And also be careful. Sometimes the family brings meals from home, and they're eating stuff from home, and that can be a problem sometimes. I've mentioned all this already. We talked a little bit about DKA. Okay, and I have this. I don't know if I can get this to work. Is there sound on this thing? Do we know if there's any sound on this thing? Don't know, huh? Well, we'll find out. Cannot locate internet. Oh well. If you just Google this YouTube thing, or you can just Google resident Atlantis nurse or something like that, you'll see this YouTube. It's one of the funniest things you ever saw. You can play it? You know how to do it? Okay, go man. You can do it. If you can do it. It's really, if you got sound, it's really good. If no sound, not going to work.
Let me just go back to your slide for that one.
It's the very end there, way down the end. I think you'd have to, yeah, you got to make it, yeah. No internet? All right. Any more questions? Questions? Dr. Hardy, did I leave anything out? I know I talk pretty fast. I talk fast, I know. I only had 45 minutes, and I've got 0 time left. 0 time left. You got Yes, you can, and it will give less. Because one of the things, the endo tool asks for the creatinine level. So the creatinine is going to go in there. It's going to give a much lower level. Absolutely, right. If you have an end-stage renal patient in the ICU, because remember, the renal patients have the more hypoglycemia. You're using endo tool to prevent hyper, but you're also using it because it has a very low incidence of hypoglycemia. So it really is safe. Yeah. Patients for what? Well, you're going to start doing it now because this has been a big problem. And we review this hypoglycemic data all the time. And the 3 biggest things are the dose was way too big to begin with, all right? Number 2 is the patient, they stopped the tube feed or stopped the steroids, there wasn't an adjustment of insulin. And number 3, about 1/3 of all hypoglycemia is due to renal patients, So, renal patients. Well, an endo tool, it has it. If you're using sub-Q, you have to, doing weight-based, you use 0.3, not 0.4, use less. All right, well, we'll forget that. Thanks anyway. That's okay. We have these blue books, and we're going to, actually, the blue book is going to be right when you go to that the home page for the hospital, where you have that red box where the up-to-date is. We're going to actually have the whole diabetes protocols, all the protocols we do in that thing. So that'll be hopefully in a couple of weeks. So you'll be able to download it or look at it. So because they charge us money to print them, and most people don't like carrying paper stuff around anymore. So, all right, I'll leave. Thank you very much.